Hello and welcome to another segment of Interviews That Matter. I'm your host Raj Mehta. Friends, in this segment we bring those guests who influence our lives. This includes elected officials, policymakers, heads of major organizations and other dignitaries. It is my sincere hope that the knowledge brought in by these guests will help our community. Today we have such guest. His name is Dr. Albert DiMeo. Dr. DiMeo is a cardiac surgeon and he has been performing cardiac surgeries for over a decade. He is currently a cardiac surgeon at St. Francis Hospital. So let's meet Dr. DiMeo. Dr. DiMeo, welcome sir, welcome to the show, and I really appreciate your time.
Thank you.
I know you're a busy man.
Happy to be here. Thank you for inviting me.
I think it's your knowledge that you're going to give today is going to really help a lot of people that who are watching this show. And in South Asian we have a very common thing that our arteries are smaller. True. And normally we do have a heart issues,
Yes.
many of us, right? So definitely it will help a lot. So thank you.
I'm happy to be here. Thank you very much.
Taking the time.
Yeah.
Right, yeah. So Dr. DiMeo, we go with your background, like you're a cardiac surgeon.
Yes.
At St. Francis. So can you tell us about you, that how did you, were you like from the childhood you wanted to be a cardiac surgeon, or how did you start it?
So I grew up in New York. I was born in the Bronx and grew up on Long Island. And I did not come from a family of doctors. In fact, everyone in my grandfather was an iron worker, my father was an engineer. I always sort of enjoyed working with my hands as a kid, but I knew I was interested in medicine. And I think putting those two things together early on, I thought I would want to be a surgeon. It was when I went to medical school that I had a chance to rotate through the various subspecialties of medicine.
Right.
And I felt then, and I feel now actually, that cardiac surgery really, for me, was sort of the pinnacle of surgery. It felt the most traumatic. It felt the most impactful. In some ways, I felt it was the most difficult thing that you could do surgically, and the challenge and the reward of that is why I wanted to be a heart surgeon.
So you kind of decided from like early ages.
Early age. I mean, I don't know that I knew specifically that I wanted to do cardiac surgery.
Right.
But I knew early on that I wanted to
go in medicine.
Do medicine, do surgery, and then later on in medical school, I sort of fell in love with cardiac surgery.
Which medical school did you go
attend? So I went to University of Pennsylvania in Philadelphia.
Okay.
And I then after that I trained at Cornell in New York City.
Oh, okay.
So and I did the path to becoming a cardiac surgeon is sort of a long path. You traditionally the path would be you would train in general surgery first. So I am a board certified general surgeon.
Okay.
That's 5 to 7 years of training. And then after that, you'll train in cardiac surgery as a secondary fellowship after training. And that is between 2 and 3 years, depending on the program. Cornell has a relatively accelerated track, and so I was able to complete both general surgery and cardiac surgery in about 7 years, only 7 years. But it was 7 years. And as a cardiac surgeon, we're also trained in thoracic surgery, which includes the esophagus and the lungs, everything in the chest. And so I had the opportunity to train at Sloan Kettering for my thoracic surgical experience. So it was a very nice training program. I did a lot of lung cancer surgery, a lot of esophageal cancer surgery, and then of course lots of cardiac surgery, which is the primary focus of my career now.
So now you are focused on cardiac surgery.
Yes, although I do thoracic surgery, and that's a different topic perhaps. But for example, this week I've done a few robotic thoracic operations. I do lung cancer, I do thymic cancer, I do esophageal cancer surgeries as part of my practice as well. And I focus mostly on minimally invasive surgery for thoracic surgery with the robot.
Do you have any family member now as a doctor right now?
So my younger brother is actually a doctor. He's an anesthesiologist.
Oh, he's an anesthesiologist.
So both my brother and I both went into medicine.
So 2 brothers and both of them.
Correct. Yeah. So now the DiMeos are represented in medicine finally. Yeah, exactly. Yeah.
So right now you are at the St. Francis Hospital.
Correct. Yep.
Now St. Francis Hospital is obviously the leader in heart
I would agree
surgeries.
with that. Yep.
So let's talk about St. Francis Hospital and let's talk about how many surgeries they do.
Sure. So it's a very interesting hospital. So I trained at Cornell in the city, which is it's part of the New York hospital system, New York Hospital, and also the Columbia system. So it's a massive medical complex. St. Francis is an unusual hospital, and it's a very small community hospital. But despite the fact that it has only 315 beds, very small hospital, we do a tremendous volume of surgery, in cardiac surgery, and also surgical research. So as an example, last year I think we did about 1,200 open heart operations at St. Francis Hospital. In a year, which is a huge volume. There are a total of 6 cardiothoracic surgeons at St. Francis. 5 of us do open heart surgery, so that volume is spread among 5 surgeons. We also do a tremendous number of transcatheter valve procedures. So one of the major changes in the management of valve disease, specifically aortic valve disease, over the last few years has been the evolution of a technique delivering the valve through the groin as a catheter-based procedure, as opposed to having to open the chest and use the heart-lung machine and so on. So St. Francis has been a leader in some of the clinical trials that evolved that technique, and we are one of the top 3 programs in the country in terms of surgical volume. We do more, I think, than any other program in New York, including the city, obviously. We did about 500 of those last year, which is a huge volume for any program, but certainly for a small hospital like ours. So the the advantage of the hospital for a person like me, as a surgeon, is that as a high volume center, we have a lot of efficiency. We have very well trained staff. The nursing staff, for example, sees so many patients. Everyone is very attuned to the patients and what their needs are. But at the same time, it's a community hospital. I'm not training anyone. I open and close my patients myself. They get, my patients get an attending surgeon taking care of them, and it feels like a small, friendly hospital. You don't have the giant, 1,000-bed hospitals of an academic center with residents and interns and medical students. It's a small community hospital, but we perform surgery at a level that you only see at the major academic centers. So it's a strange place. It's a unique kind of hospital in that regard. Both of my parents were patients there in the last few years, and I can say that the care they got was wonderful. And I really felt I was very proud to be there, knowing that that's the kind of nursing care that we deliver, the kind of quality that the patients receive when they're there.
So is it like basically it's a leadership, right? I mean, leadership is kind of emphasizing on, because they're like, they must have focused on heart.
Yeah, so it's an interesting, the history of the place is very interesting.
Right.
The hospital was founded by nuns originally as like a summer program for children with rheumatic heart disease. It was like a camp and almost like a hospice for kids with rheumatic heart disease. These were children that got strep throat. There were no antibiotics back before the 1940s, and they became very sick, and the hospital was there to kind of rehabilitate them and help care for them. So that was the origins of the institution. And then later, after the evolution of antibiotics and rheumatic disease began to fall away, the hospital, because of its interest in children with cardiac disease, began to become involved with adult cardiac disease, which was really the new kind of frontier of cardiac disease at that point. And we became the first and eventually only hospital recognized by New York State as a specific cardiac center. And that is sort of the evolution of the institution. I mean, the history of cardiac surgery is that the first operations were performed for congenital heart disease, children that had anatomic abnormalities with their heart. After those operations were kind of pioneered and then perfected, the next phase was treating adults with valve disease. And these were often the adults that had rheumatic disease as children. St. Francis was involved in the earliest stage with the children, and then later with the adults with valve disease. Then in the 1970s and 80s, coronary artery disease, blockages of the arteries, began to be treated with bypass surgery. And St. Francis was one of the top programs in the country almost immediately in the management of that disease. In fact, volume-wise, at one point in the 90s, I think the only hospitals that were busier than St. Francis were the Cleveland Clinic and Baylor in Texas. We were an incredibly busy program, busier than all the other programs in the city. And that culture, and as you say, that leadership, has been maintained, so that even now we are, we're one of the busiest programs around. It's a very unique kind of place.
Wow. Yeah. No, I mean, I can understand that, And like you have a separate research wing.
Correct.
Right?
Yeah. So,
San
so
Francisco.
they have what they call the DiMeo campus, which is a large campus on Northern Boulevard that is dedicated to cardiac research. You know, the cardiac research divisions of the hospital are interesting. We have our own in-house researchers in doing cardiac imaging, cardiac MRI. There's a tremendous amount of research happening with percutaneous coronary interventions from the cardiologists in the cath lab doing stenting and so on, cardiac imaging in intracoronary imaging, and then also the stuff that we're doing with the valve, the newer valve technologies that we're participating in. So it's a combination of pure academic research, also research partnered with industry because of the large valve companies that are trying to pioneer these new valves are working with us and start running their clinical trials. So there's a lot of different stuff going on. It's again, for a community program, it's unique.
So you mentioned many times valve issue.
Yes.
Now, can you tell us something more about that? I mean,
Sure.
who can have it? How can we know?
Right. So the heart's a pump.
Right.
And like any pump, it needs to move a fluid in one direction. So the way that works is valves open and valves shut.
Right.
So there are basically two major type of valve issues that can evolve. Your valve can leak, or your valve can become tight or stenotic and not open properly. So as we age, just like we get cataracts, we get arthritis, the valves can calcify. And a calcified valve becomes stenotic. It doesn't open properly, like a door with a rusty hinge. And initially, if you go back to the early days of cardiac surgery, this was not a problem that surgeons dealt with. But as we've gotten better and we can do more and more safe surgery, we now have lots of people in their 80s, their 90s, even over 100 that have valve disease that we can now surgically treat. So the standard operation involves opening the chest. We can do that through minimally invasive incisions as well. And we all, I do that, and all of my partners do that. But regardless, standard open surgery where we get into the chest, we have to put the heart on the heart-lung machine, stop it, open it, and replace the valve. And there are various types of valves that are available, ranging from manufactured valves made of a metallic material, what we call a mechanical valve, to valves that are made of cow tissue or pig valves, all the different things that we have available to us. But one of the newest things that we have now is a valve which is mounted on a catheter. And just like it goes up through the groin like a regular catheter, and that valve is deployed, and while the heart is still beating, expanded into place, pushing the old valve out of the way and seating in the new position. So over the period of a few seconds, you go from a stenotic valve to a new valve. There's obviously issues related to that procedure. It has to be done very carefully, a lot of preoperative planning, making sure the sizing is correct, making sure we don't cause a stroke, don't rupture the heart. But that's a procedure that we're doing a tremendous number of now. And in fact, it's becoming one of the most common valve procedures for aortic stenosis around. But there's other valves in the heart as well. The heart has 4 chambers, so each chamber is associated with the valve.
Right.
And those other valves are also often operated on and or now being replaced or repaired using percutaneous techniques. For the leaky valves, we generally will repair them. For the stenotic valves, they need to be replaced.
So with, you figure out by doing the X-ray or...
Right, so the echocardiogram, which is an ultrasound analysis of the heart, can show us in real time how the valves are opening and closing. And in addition to that, a significant component is the patient, how the patient feels, their complaints. There are different types of changes that the heart will develop in the setting of valve disease. It will thicken because it has to pump under a lot of pressure, and like any muscle, if you put it under pressure, it'll get bigger. But the heart's a hollow organ, so if it becomes too stiff or too thick, it doesn't fill. So we need to watch the heart to see if those changes are taking place. If the valve leaks, the heart will dilate to accommodate the extra volume, and that can stretch out the muscle so it stops beating well. So those are the changes that we look for, primarily on echocardiograms. So for valve disease, which relates to the pumping action of the heart, a functional study where you're looking at the heart moving under ultrasound with an echo is helpful. For coronary artery disease, which is really a plumbing issue, the heart muscle is not getting enough blood. That is where we look at it using angiography, where we do a cardiac catheterization, put dye in the arteries, and we can see how they look. Although nowadays we have CAT scan available, which can often be used to help us. And there's other ultrasound imaging inside the arteries of the heart that can be done as well, which our cardiologists at St. Francis do more of a certain type of cardiac imaging called OCT, which is it uses a laser inside the artery to 3D map the walls of the artery we do more of that than anywhere else in the world, actually, at St. Francis.
Laser, using laser?
Yes, and what it does is it shows the cardiologist not just the narrowing inside the artery, but it shows the wall of the artery. The artery is a complex organ. It's made up of several layers of cells, including muscle. If you get blockages in the arteries, it's not just like there's a plaque inside the artery, like inside a pipe. You actually get growth inside the wall of the artery of inflammatory cells, of cholesterol deposits, of different types of tissue, and you can see calcium, fat, plaque inside the artery in various ways using this technique, which is only available otherwise if you take out the heart and you slice it up. And so now we have the ability in real time in live patients to look at this, and this is changing the way they're managing the disease. And this is stuff we're doing more of anyway at St. Francis than anywhere else.
Wow.
Yeah.
Wow. So it definitely is like non-invasive and
correct.
Like laser, obviously laser is becoming more popular in many surgeries.
Yeah, exactly. It's sort of amazing.
So
well, this is like almost like a scanning laser that allows you to the light waves bouncing back is how they analyze the tissue in question. So yeah.
Very interesting.
It is.
Very interesting.
It's a fascinating evolution from simply cutting and sewing to the sort of more modern stuff that we're doing now.
Wow.
Yeah.
So tell me something that how long, what was the first surgery look like when you did? When did you do the first one?
So it's I can't even remember my first surgery per se because as a trainee, as a medical student and as a trainee, you're allowed to do certain small parts of the operation that are considered safe. So as a medical student, I might be able to put a few stitches in the skin, depending on the rotation, maybe do a little more, do this, do that. As a cardiac fellow, my first complete operation, skin to skin, probably was either an aortic valve operation or a bypass operation, which we did. Cornell was a very busy program. We did quite a few of. I graduated as a fellow with more than 1,000 open heart surgeries that I had, that I had essentially done with the supervision of my attendings. And
you yourself did it? I mean, somebody supervised?
Yeah, it's a team effort though in cardiac surgery. So. I may even today I'll do essentially the entire operation, but I have people assisting me throughout the surgery, and they'll be cutting sutures, retracting, putting stitches in this or that, helping harvest vein if we're harvesting vein. If we're using a radial artery, they'll be helping harvest the radial artery. So we'll have people involved in the surgery, even if the captain of the ship, if you will, the cardiac surgeon is responsible for everything. But at an institution like St. Francis, where we are not in the business of training people to learn how to operate, we do the whole surgery in a way that isn't true at a training hospital, which is fine too. I mean, I'm a product of that. All of us are. But at a place like Cornell, you have fellows, and your goal is that they can graduate and they can do these operations independently. You have to allow them to do more and more of the surgery as they go along. So we don't have that.
So how long you have been doing this?
I finished my training in 2005. So I've been out of training in full practice now for about 14 years.
Right?
Yeah, exactly.
So there's a lot of evolution between the surgery that time and now.
It is. It's changed a lot. I mean,
when
I graduated, I was not doing any minimally invasive surgery, which I'm doing now. When I graduated, there was essentially no robotic. There was some, but really minimal robotic surgery. I do quite a bit of robotic thoracic now. The transcatheter valve procedures had not been invented yet, so none of that stuff existed. I do a fair amount of procedures for ablation of atrial fibrillation, correcting electrical arrhythmias on the heart, and that's something that we were doing some of the research in that when I was a fellow, but it's a completely different procedure now with new energy sources that have been invented. So I would say on a given day, when I operate, a significant portion of what I do is different in some ways than what I learned, 15 years ago.
Wow. Yeah.
And it's only going to be more different in the future.
You have to keep learning.
Well, that's one of the things about the job that is interesting. Even if we are doing, a similar type of surgery, we're doing bypass surgery, we're doing valve surgery. The changes in the technology, the changes in the technique. Keep it interesting, and it's a continuous educational process for us, which is kind of fun.
Who trains you on these things then?
Well, a lot of it is is a matter of reading, going to meetings, talking to other surgeons. The changes are often so incremental that you can incorporate them in your practice without really having to do anything dramatic. But if there is something new, like for example a transcatheter valve procedure, which is a new procedure, then the process of training involves going, generally traveling somewhere, watching live cases, a dog lab or an animal lab of some kind, where you're learning it on a pig or on a dog, and then working on cadavers, and then eventually bringing it to your patients. And even then, it's a heavily proctored approach where you'll have people. Many of these procedures, in terms of the new valve, any of the new technologies, tend to evolve in Europe before America now, even if they're American companies. Like for example, Edwards, which is one of the pioneers of the transcatheter aortic valve, that's an American company based in California. However, most of their research was done in Europe because the FDA is very restrictive in what we're allowed to do here. It's much more lax in Europe, and so they can do human trials much more easily in Europe. So inevitably, the European surgeons are a little bit more advanced than we are. So we've had proctors from Italy and France and Germany come over and show us sort of how to do those procedures when we start implementing them here, when they get approved by the FDA. So,
interesting.
Yeah.
We'll take a short break and we'll be right back.
Great.
Please
Sounds
stay
good.
with us. Welcome back to Interviews That Matter. I'm your host Raj Mehta. We're getting a wealth of information from Dr. DiMeo. Dr. DiMeo is a cardiac surgeon and has been doing surgeries, I guess, like a mechanical thing. Like it's like a third sense for him now. He's been doing it for a long time, and he's done many surgeries, cardiac surgeries. So, Dr. DiMeo, welcome, sir.
Thank you.
I actually want to ask you now in layman term, like, for example, if I'm sitting in a home and obviously, how do what are the symptoms that warns me or alarms somebody? And I know it's not everybody doesn't have the same
Correct.
symptoms.
Yeah, that's one of the
like generalizing.
Yeah. So one of the big problems with recognizing of cardiac symptoms is that they can often be interpreted as something else, or they're subtle enough that they're unrecognized. So the classic signs of, say, for a heart attack, which most people don't have, but the classic signs would be crushing chest pain, shortness of breath, pain radiating down the arm or into the neck, and a feeling of intense pressure in your chest. The fact is, in female patients, for example, very small numbers of patients actually experience those symptoms, and many diabetics don't experience those symptoms either. So what would be an alternative symptom that people might experience is a sense of heartburn or nausea. They can also have shortness of breath and dyspnea, shortness of breath with exertion. And it's often easy for people to pass those symptoms off as I'm getting older, I'm out of shape, I ate something I shouldn't have eaten. And so there is, unfortunately, about half of patients who do have a heart attack will not actually recognize those symptoms when they have the heart attack. So it is not a common thing that's easily determined. For people with more advanced cardiac disease, valve disease, specifically issues with the heart pumping well, the main symptoms people will notice is retention of fluid, so swelling of the legs, difficulty breathing, difficulty laying flat in bed, sometimes a cough which produces sort of a frothy sputum, but not anything that looks like an infected, upper respiratory infection, and fatigue, and just fatigue. And it's amazing how many patients will often talk to me before surgery for, let's say, a valve disease. And they'll say, I really feel okay, there's nothing wrong with me, I don't have a lot of symptoms. After surgery, they'll say, wow, I feel so much better, I didn't realize how tired I was, how run down I was. And that's really where the physiologic testing that has to be done preoperatively can help us, because the more subtle the symptoms, it's often difficult to determine, is it really the heart, or is it the patient's getting older, is there a problem with their lungs, is there something else going on? And the echocardiogram, the angiogram, nowadays cardiac MRI, can really help us to determine if that's really what the problem is. And of course, ultimately, we don't want to operate on people if we're not going to make them live longer and feel better. Those are really the only reasons to operate on somebody. And especially nowadays with the elderly population that we're dealing with. So for example, for aortic valve disease now, a large percentage of our patients are in their late 80s or early 90s. In fact, we did a 103-year-old patient about a month ago.
Yeah.
So it's it's an incredible thing that you can actually do these operations on people that old and they do well. But again, there's no point in doing an operation on somebody who's 100 years old if you're not going to make them live longer and feel better. You really have to be giving them a benefit. And so separating his age from his symptoms sometimes can be difficult. That's where all the testing really comes in handy.
So, like when there's a there has to be a line drawn, right?
Yeah.
Okay, like many times, if you have like these symptoms and then it stops and goes away.
Yes.
And then, but if it is prolonged for a long time, that's when it's kind of alarm system.
Yeah, I think so. And then I also think that if you have a good relationship with your regular medical doctor,
right,
especially if you have a strong family history, say of heart disease,
right,
then there is a real role in preventative testing. Not just in preventative medications, but also getting a stress test, for example, and just taking a look and see how things look, getting an echocardiogram and making sure the heart looks okay. And changes like that, or I should say testing like that, can really help alert you before there is a problem. Often patients will say to me, my EKG looks normal.
Right.
The EKG is an electrical, analysis of the heart rhythm, and it will look normal if you haven't had damage to the heart muscle. But you can have impending damage to heart muscle without a change in your EKG. For example, you can have a critical lesion in the arteries of the heart that hasn't caused a heart attack yet, but will, and it needs to be addressed before it causes severe damage, and EKG won't tell you that, but a stress test might, or an echo might give you that information if it's a stress echo. So those are the kind of things that I think, again, having like a good relationship with your primary care doctor, if they understand your family history, they're aware of your other health issues, they can keep an eye on that stuff.
So primary care doctor is a key.
I think so, right? And certainly if you have a strong history in your family of heart disease, or you yourself have any issues, then obviously a regular cardiologist, a good primary cardiologist, is probably the best person to keep an eye on you.
So family history is more important. That you have to kind of, and what I think is that, heart attack or getting the clogs in the arteries and all that, it doesn't happen overnight. It happens
over
like,
many years,
when you are like, 20s or something like that. And then, when you're really 60s, that's when.
Correct. So in fact, after the Vietnam War, there was a study looking at the at autopsy studies of young American soldiers. And what they saw was that even soldiers in their 20s already had signs of streaky fat deposits in the coronary arteries, so they already had some signs of that. And yes, it's not clinically significant at that age, but as you get older, it builds up over many years, and that's why it's exactly right. Preventative medicine is helpful. Probably a big change that has made a big difference in lives is the use of anti-cholesterol drugs like Lipitor. That has certainly reduced the volume of patients that I operate on and what the cardiologists have to do. And that is a combination of lowering cholesterol, which is important because many of the deposits in the arteries of the heart that cause blockages are laden with cholesterol. But it also has an anti-inflammatory component. And some of what happens in the arteries is happening at an inflammatory level as well. So things like that, the medical management has made a big difference in how people do.
So let me ask you this, that if someone has a family history, and it's kind of a matter of time when that can happen. I mean, normally family history are the primary candidate, right? So let's say somebody has already a family history and they start early on Lipitor. Would that prevent them from having a heart attack?
It certainly can help quite a bit. I think if you have a family history and of hypertension, hypercholesterolemia, problems with diabetes, if those are medically managed appropriately and early, it can make a tremendous difference in how you do. I mean, in general, people are living longer and living better later in life now than they were in the past. Even with really an epidemic of coronary artery disease that we're seeing now. Some of that is changes in lifestyle, changes in diet, but even with that, in general, people are doing better. And that's a reflection of the good medical management, basically. Yeah.
Yep. So once in a year, go to the primary care,
Yeah, I
make
think
sure
so.
that your tests, all the tests
Yeah,
are
the blood
ran,
tests are checked.
blood
Everything
tests
looks
are
okay.
checked, everything is checked.
Exactly, and then usually, like if you have a strong family history of heart disease
Right.
in your 50s, it would be it would be worthwhile getting just a stress test to take a look and make sure things look okay,
Right. Okay.
and then
so
pay attention to any symptoms that you might have.
and then start early on Lipitor or whatever the cholesterol medicine
Yeah,
is.
whatever the
Whatever that is
recommendations would be.
prescribed,
Correct.
basically,
Yep.
right?
Exactly. Yeah.
And okay. So I guess we do our best, and then whatever happens, happens. Is
Well, I know that. I mean,
is that-
is
that a good statement or
I
no?
think that's true, and I feel like in my line of work, I am.
Right.
I'm sort of the end of the line. When by the time people come to me,
Right.
it means you need to have a big intervention.
Right.
The advantage, I guess, if you will, of modern cardiac surgery is that we can do more and more safely than ever
Right.
before with
Right.
very good results. And so
Mm-hmm.
I often, when I do operate on people,
Right.
the vast majority of them will go on and live normal lives, healthy lives, be active, be able to live their lives when they recover from the operation. That's sort of the advantage of modern cardiac surgery.
So modern cardiac surgery, there is a. I mean, I'm not too knowledgeable about this, so excuse me for that. But some people have a lot of pain, and some people don't have any pain when after the surgery.
Yes,
Is
that's
there
the mystery.
is there any kind of
Well, I mean, the all surgeons will tell you that in general, women have less pain than men,
right?
and younger men have more pain than other patients. Pain is this is a whole. I mean, it's almost like not even a medical conversation. It's almost like a philosophical conversation.
Okay.
There's nothing more painful in the world than childbirth,
Right,
and
right.
yet for millennia, women have been able to tolerate it,
Right,
and it's
right.
in part because there's a psychological component to pain, which is a legitimate, which is a major component in pain. You can have pain, but if you understand that you're suffering for a purpose,
Right.
it has an endpoint, a finite endpoint in mind. People can deal with it, and that's sort of childbirth is a perfect example of that. You're going to have a baby, and it's going to be over.
Right.
For some people, post-operative pain, people I think with perhaps. I hate to say it like this, but people with maybe the right attitude about it, understanding that this is something they have to get through to
Right.
get to the other end, and if they
Right.
power through, they're going to make it. They really tolerate pain much better. And other people with perhaps a different perspective are much more, suffer much more with it. There's also undoubtedly a neurologic component to it at the level of the pain receptors. Some people just have terrible pain and other people don't. You'd be amazed at how many people I operate on. After I open their chest, a week after surgery will say, I have no pain at all, I feel fine. It's incredible to me, even though obviously I've traumatized them in an enormous way. And also there's other changes too. Different incisions have different types of pain, and the way we do things now, I think, the way I close the chest, I think is actually less painful than how I used to do it. But it's always a mystery to me why certain people have more pain than others. I don't think there's a real good answer
So
to
it
that.
can be a psychological issue. It can be like more of a positive attitude.
I think so.
I mean,
so.
you're right. Positive attitude towards.
Completely. I mean, I really am a big believer in that. I see that all the time, and you don't want to blame the patient if they're having pain or if they're not feeling well.
Right.
But there's no doubt that in my own life, in the lives of my patients, that people, the way somebody approaches a certain set of problems has a big impact in how they feel and how they recover. Yeah.
What is a typical? How many hours typical surgery takes?
So
approximately.
For me, the actual time I spend operating, for example, for bypass surgery or valve surgery, is somewhere in the range of 3 to 4 hours on average.
On an average, okay.
But when you factor in the time going into the operating room, the prep time, for the
Right.
patient, and then at the end of the procedure, we have to get the patient dressed up, packaged up, and transported safely out of the operating room. The whole thing tends to be closer to 5 hours usually.
So normally 5 hours is kind of typical.
Fairly typical for cardiac surgery.
For cardiac
for
surgery.
some of the other operations I do, those can be much quicker. They can be an hour or two, something like that.
Yeah, and what is the longest time that you have taken in?
So the longest I've ever been in one operation
one
was probably
operation.
about 18 hours, actually.
18?
Yeah.
What did you do for 18 hours?
Well,
I mean that's complex.
because some of the more complex cardiac operations that we do, especially traumatic would be related to the rupture of the aorta.
Uh-huh.
The aorta, the big blood vessel that comes off the heart, takes all the blood out of the heart. If you get a severe aortic tear and rupture of the aorta,
Right.
that can often, about 50% of the time, it will cause instant death. And for those that make it to the hospital, it's a very big deal, emergent surgery. The technical aspects of a big aortic operation, especially under emergency circumstances, involve cooling the patient, actually stopping all blood flow in the entire body for a period of time while you're working on certain of the vessels, and then restarting the blood flow, restarting the heart, and so on. Those long operations are not spent necessarily operating nonstop. There's long periods of time, especially towards the end, where you're dealing with bleeding issues. Because one of the banes of the kind of surgery that I do, cardiac surgery, aortic surgery, is you're dealing with blood vessels that are under pressure, that are and you're working directly on these arteries, and
Right.
if they bleed for any reason, fixing them can be very difficult, because getting access to them while the heart's beating and so on. And the nature of these operations involves blood loss and involves, generally speaking, loss of normal clotting.
Right.
And so, especially nowadays, many of the patients we operate on are coming into the operating room on Plavix or these other drugs that are not good if you're operating. They need to be on them for other reasons, but in emergency settings, when we don't have the chance to stop them before surgery, we just have to deal with it. So one of these super long operations, like I described, maybe 6 hours of that operation is spent just trying to stop bleeding and try to get the patient safely off the operating room table. That's thankfully very rare, very, very rare. But yeah, I have been there.
18 hours.
For about 18 hours.
Continuous. Wow. So let's go into the operating room
Yes.
now, right? So for example, like a patient is there prepped by
Yes.
the different nurses or whatever,
Yes.
and if let's say I know that if somebody is herring, then they just take out their
Sure,
hair,
exactly.
and then the anesthesiologist comes in and gives an anesthesia, and they count 1 to 10, and you're out.
Exactly.
The person is out,
Yes.
right? And then
After that, a lot of other stuff has to happen before we
exactly.
can
So
operate.
that's what we need.
So, for cardiac surgery, any
Right.
major operation,
Right.
monitoring of the patient during the surgery is very important.
Okay.
We want to monitor their blood pressure. We want to monitor their, the what we call their filling pressures, the volume of blood inside the major arteries of the heart, and that involves catheters. So arterial lines of blood, a line that goes into your wrist to measure your blood pressure, maybe in the groin as well. And then lines in the neck that are large bore, large IVs that can give blood, give transfusions of volume, like saline, for example, and also can measure pressures inside the heart. And the more advanced monitoring lines that are used can measure your cardiac output, meaning how much the heart is ejecting with each beat, and can give us a good sense of the various performance of the right side of the heart, the left side of the heart, and so on, which is helpful in monitoring pre and post-operatively.
Okay.
Addition to that, there's going to be catheter inserted for measuring urine output and those sort of things. Then we have to pad the patient all over so they don't have any nerve injuries, prep them, drape them with all the sterile drapes and materials, and then we get started. And for most open heart surgeries that we do now, the patient's going to be placed in the heart-lung machine during the operation.
Right.
So once we open them up and get access, we have to insert large catheters or cannulas into the heart, drain the blood out of the heart, goes to the heart-lung machine that's run by a perfusionist who's a specialized technician who runs the heart-lung machine. That blood is given oxygen, it's warmed or cooled depending on what we're trying to do, and then pumped back into the body. We have to get these cannulas in the heart to allow the blood to circulate. And the reason why we do that is because if we're working inside the heart, you can't work inside a heart that's full
While
of
the
blood and the
blood is
patient's going to bleed
flowing,
to death. So those cases will stop the heart. And
Right.
we stop it by isolating it from the circulation and giving something called cardioplegia. Cardioplegia is essentially paralyzing the heart. It's a solution that contains high levels of potassium.
Wow.
And high levels of potassium will basically arrest the normal conduction of the heart. The cells won't contract, and so that will stop the heart from beating. The advantage for the surgeon is I don't have a heart that's beating while I'm trying to sew on it.
Right,
And the
right.
advantage for the patient is if your heart is not getting normal blood circulation,
Right.
by definition it's not getting any blood.
Right.
It's in danger of getting injured.
Right.
By causing the heart to stop moving.
Right.
It puts it into, and it also cools the heart quite a bit.
Right,
It puts
yeah.
the heart into sort of a hibernating state, which is safe while we do what we need to do. When we're through, the heart starts beating again because normal blood supply is initiated, all the potassium washes out of the cells and they start beating again. We're back hopefully to normal heart function at the end of the operation.
So
then we got to reverse everything we did,
right.
make the blood clot appropriately, close the chest, and then and then we're done with the surgery.
So the pump becomes a heart.
Correct.
For
there's
at
no
least whatever,
there's no ventilation.
couple of hours or whatever.
Well, for most of the surgery they do maybe like an hour and a half. But for for very complicated long surgery, sure, maybe 4 hours, which
right.
is really a long time.
Right. Yeah.
The problem with the pump is that there's a risk of injuring the blood cells, and so the longer you're on the heart-lung machine, the more you're going to have bleeding after surgery, the more anemia you're going to have, and so that's part of the reason why we try to limit that if we can. But certain very complex operations require a long period of time with the heart-lung machine.
And to open the heart, you have to break the bone.
Yeah, so there's various ways to get in there, but the
right.
most standard way is to divide the sternum down the middle, the breastbone down the middle with a saw.
Right.
We can also get in between the ribs for certain types of operations.
Right.
For some of the minimally invasive procedures, you can go lateral to the sternum, and often you'll have to divide a rib, or just divide the upper third of the sternum to give you a little bit of access up here. And there are advantages to smaller incisions, obviously, that we sometimes do as well.
So you determine this before?
Yeah, and it's really
or
determined.
at the time?
It's really determined by the operation. So, for example, if you're doing bypass surgery,
Right.
you need a lot of access to the heart because
Right.
you're working on arteries that are on the surface of the heart.
Right.
And so you need access to all various parts of the heart. And if you're going to be doing more than 1 or 2 bypasses, you really need to get enough room to be able to safely look at the surface of the heart and move it around. And so that's why we would almost always do a standard incision with that. Yeah.
And when you do the bypass surgery, once you replace the, there is a difference between vein replacement and artery replacement.
Yeah.
Right? And so you determine whether it's a patient is supposed to
Right.
get
So
what kind of.
generally speaking, so as a general rule, if you're going to be doing bypasses around blockages on the heart, if you can use arteries, they're better than veins because arteries are designed by God to carry arterial blood. Veins are not really designed to maintain the wall integrity for that kind of blood pressure, and so you can get vein failure over time. The veins can close off, they can clot off, they can fail. Generally speaking, for younger patients, where you're trying to give them the most durable operation possible, operation that'll last them as long as possible, we try to use more arteries. The disadvantage of using arteries is that if a patient is obese, diabetic, using both of their internal mammary arteries can increase the risk of a wound infection. And so you have to measure the risk of an infection of the breastbone is a horrible complication. Very rare, thankfully. Very, very rare. But even if you have 1 out of every 500 patients, it seems like a lot. So you have to weigh those risks versus the benefits. We use radial arteries as well for bypasses in patients. The advantage of a radial artery is that it's a beautiful, nice arterial conduit. The disadvantage is that radial arteries generally are not good for use on small arteries with bad flow coming off of them. So for people with bad diabetes with very small arteries, radials can close off earlier than vein even. So you have to weigh some of the physiologic considerations, the anatomy, against what you think is going to be best result for the patient.
Again, you decide this before.
Usually before. Usually we can determine if we look at the cath films, we know what the patient looks like, we understand their history, we can usually make an determination before. Sometimes we'll get in the operating room and we'll look at the vein and the vein will be terrible. It won't be usable vein, in which case we have no choice but to then harvest some other arteries in order to do the operation. But usually we'll know in advance when we get in.
So when you use the radial artery, right?
Yes.
You said that it is, it can clog earlier.
Well, it depends on what you put it on. So for example, I would use a radial artery on a large vessel that has a very tight proximal blockage. If you use the radial artery on a very small vessel that doesn't feed a lot of muscle, it doesn't really, the flow limitations through the artery can increase the likelihood that it will close down early. So the radial is a conduit that I think you need to be thoughtful about what you put it on. It's not for everybody.
Okay. And how many people are in the surgery room?
So during an operation, we have an anesthesiologist. We have an anesthesiologist.
He's there all the time.
Pretty much. Although when we go on the heart-lung machine, there's not a lot for them to do.
Right, but
because
they're
at that point, they're there. But at that point, there's not a lot for them to do.
Right.
But the anesthesiologist is there, obviously.
Right.
We'll have the perfusionist who runs the heart-lung machine. We'll have a physician assistant who's usually there to help with the operation. Also, maybe harvest vein, help us with that. We'll have myself, the surgeon. I usually have a co-surgeon that is also there to assist me with the surgery. And then we'll have 2 nurses, one who will scrub in who will actually be the one giving us the instruments and helping during the surgery. And then another nurse we call the circulating nurse, who's on the back in the room, making sure that everything we need is available for us. Sometimes during surgery we'll say, oh, we need, for example, valve surgery. I need the valve now. I need this. They'll be able to, to give us that stuff as we need it. Yeah.
Okay, so there are about 7 people.
Yeah, it's a big team.
A big team, 7 team of.
And then depending on how long the surgery goes, people are coming in and coming out because they're exactly.
Right.
Yeah.
Wow.
Yeah.
Amazing.
It's fun. I mean, when the surgery is going well, there's a lot of coordination. There's a lot of collaboration, and it moves smoothly. It's a nice feeling to have all those people working in unison together. It's good.
So now, what I've heard is that, earlier, like, people are having now earlier, like in 40s, they're having these heart issues.
We're starting to see a little bit more of that.
You're starting to see that, right?
I think it's a consequence. I mean, it's a well-known phenomenon. If you look now, there's increasing obesity, increasing diabetes, and those are big risk factors for coronary artery disease. And so I'm starting to see people I'm operating on that are younger than me, in their early 40s now, that would have been less common in the past. Historically, there was a lot more cigarette smoking than there is now, and the decline of cigarette smoking is definitely a huge health benefit for people. But the it's a modern diet of eating all the fast food and the sugary drinks and everything, that there's a lot more obesity, there's a lot more even pre-diabetes, metabolic syndrome, and that is an increased risk for coronary disease, no doubt about it.
So diet is also kind of makes a difference,
important.
Right?
Sure,
Very
diet and
important,
exercise,
like,
that's really the key to everything.
Right.
But of course, it's hard in modern life with the work that people do, the way we work, the hours that we all work, commuting in a car back and forth. I mean, to do what we all should be doing for ourselves. In some ways, our grandparents, with all of their own challenges, because they were, because they had to walk more, because they didn't have all the foods available that we had today, they were healthier in their own way than we are today.
Fresh food. That kind of thing, mostly fresh food and home cooked food rather than restaurants all the time, packet stuff, frozen food, this kind of thing, right?
I know anything that comes out of anything that comes out of a package is designed to for you to want to eat. Has too much salt and too much fat and all the preservatives and everything. I agree completely.
Right. So then definitely people should reduce that amount.
I agree completely.
And just eat even small thing you eat fresh. That is far better
100%.
than. Right.
I agree. Yep.
Yeah. Now let's talk about the preventive. What one should do to kind of prevent. I mean, we talked about this before a little bit, but let's summarize it.
Sure. I think in the end, I think the most important thing is, number one, it's a lifestyle, issue, diet and exercise. I mean, we all know that. You don't need to be. You don't need to be a nutritionist to understand that. A healthy diet involves mostly plants. Right, vegetables, fruits, not too much red meat. You want to avoid high-fat foods. You want to avoid processed or packaged foods. We all should exercise. I mean, the current recommendations are about a half an hour of exercise a day. For most people, if you're just taking stairs, walking around, and just getting your steps in every day, trying to be active, that's the best thing you can do. You don't need to go to the gym and lift weights. You just need to be walking and doing stuff like that. And then after that, the next thing is to pay attention to your family history of health issues. If you had parents that at a young age had cardiac disease, you have siblings that have cardiac disease, you should keep that in mind. And then good preventative care with a good doctor, whether a cardiologist or a primary care doctor, who will keep an eye on you, make the appropriate recommendations, and do the appropriate tests as needed. And then pay attention to how you feel. People in their 50s or 60s should still be able to run around and do stuff. And if they feel like they can't, it's not just getting old. It's usually that there's something else going on. Right.
That's a kind of a signal.
Yes,
that
I agree.
You have to definitely kind of take care,
there's something going on. It's something going on. You need to look into it. It's not just that you're getting old. There's something else happening. Right. Exactly.
Let me come back. I'm sorry, I missed this, but let me come back to aortic.
Yes.
There are aorta here, here, and here, three.
Well, the aorta is what we call the ascending aorta, which comes off the heart. Then the aortic arch, where it turns and goes down, and then the descending aorta, which goes down through the chest into the abdomen.
Okay, so right here, one goes down and come up like this?
Well, no, it comes off the heart in a loop and goes like this down the body in one long continuous artery.
Oh, so it's a continuous thing,
Correct.
basically,
Yeah, but
right?
then we talk about zones of the aorta, but it's one long continuous artery. Yes.
And aorta is the one who kind of does the blood flow to all of the
Correct. The whole body. The
whole
branches
body,
into the legs. It
branches
gives all the
in the
blood
leg.
to your abdomen, your kidneys, your liver, your guts. In the chest, it gives branches to the chest wall muscles and into the lungs, and then here to your carotid arteries, to your brain, and into your arms as well. Yes.
So these arteries are also bigger,
Yes.
larger than normal.
Well, they're larger than
Right?
other
They're
arteries.
larger than normal.
Yeah.
So if somebody has any kind of, how do they feel that there is a problem here or not?
Well, carotid arteries are interesting.
Right.
I mean, you often
Yeah.
your doctor will listen in
okay.
the office and listen for what's
Right,
called a
right.
bruit to hear if there's issues. Certainly, it's a risk for stroke if they become very tight. That's easily analyzed with an ultrasound. Probably the easiest test is just an ultrasound of your carotid arteries.
Yeah.
They'll actually have screenings often, like free screenings where you can get a quick carotid ultrasound because it is worth looking at. All of my patients preoperatively, before I do heart surgery, I like to look at their carotid arteries because if you have coronary artery disease, it's not uncommon to have carotid artery disease, and so I always check and make sure that they're okay.
What future holds, doctor?
Yeah.
I'm seeing it like less and less invasive nowadays.
I think that's true. The
So-
future is right now. The future is sort of here with aortic valve disease, with all the transcatheter valve procedures, which in really a few years have gone from being something that was used only for inoperable patients to now being used for almost everybody. The next big push that we're going to see is going to be management of the mitral valve. The mitral valves is another valve on the left side of the heart that is often the big problem in America is that the valve will leak. You get mitral valve leakage, and the management of that is actually much more difficult than aortic valve disease. But there are a whole bunch of new technologies that are evolving for transcatheter management of that valve. In the next decade, that's going to be coming online. I think as a real treatment option for that. There are multiple different experimental devices. We're involved in a few of them at St. Francis that are very promising, and I do think it's going to be about 10 years. But I think in about 10 years we're going to actually have some usable transcatheter mitral devices that are going to be much more common. And then at that point, between the stenting technology, which is getting better and better for the heart, and the transcatheter valves, there's going to be a tremendous amount of non-invasive management of these diseases. It's going to be a very interesting time.
Stenting, you mentioned stenting, right? So somebody, there can be a patient which are good for stenting.
Yes.
Or some patient has to be doing bypass surgery.
Correct. And in fact,
Right,
nowadays, the vast majority of people are managed with stents, but there are certain anatomic variants that are much safer treated with surgery than with stenting. And surgery, as a rule, bypass surgery, as a rule, is more durable than stenting and has better long-term results.
Okay.
That's a broad generalization, but that's essentially true. The downside of bypass surgery, of course, is that it's much more traumatic because it's a big operation.
Right.
So the management decision, needs to factor that in place. People who are very high risk or very elderly, obviously stenting would be appropriate. Only one or two vessels are blocked, stenting would be appropriate because the surgical advantages aren't really there. But for people with certain types of disease, certain anatomic variants, diabetics do much better with surgery than stenting. There's a large subset of people. It keeps us, even in the modern era, we're very busy with bypass surgery. So there's still plenty to do.
So it's like if it is 80% blocked, 100% blocked, then obviously bypass.
Well, it's not necessarily the percentage of the
It's not a
blockage.
percent.
It's more the location of the blockage and the vessels that are involved. So if you have the blockage of the left main trunk, which feeds the whole left side of the heart,
Right.
that's something that is much more difficult to stent safely, because if you can imagine, if you have if you have a large artery with two large branches and the blockage is extending to within the
Right.
branches, if you deploy a stent here, you can push everything closed over here and vice versa. So it becomes much more dangerous, whereas surgery, safely bypassing both of those, can give you a better result. So it's anatomical variants like that are still the reasons why we operate. The cardiologist will say, I don't think I can safely perform a stent.
Oh.
Totally blocked vessels are much harder to stent, but nowadays they are able to do a percentage of those in the cath lab. But those are also generally, as you say, an indication for surgery right now. Yes.
So cardiologist does the stenting.
Correct. Yeah.
Right, and cardiac surgeon does the open heart
Open
surgery.
heart. Correct.
So cardiologist, when he is the one who's going to decide whether is this or not.
That's correct. And basically,
I can't do stand.
Exactly, and that's what happens. Basically, they get the first crack at it because
Right.
it's their patient, and if they can't do it, then they call us.
Got it.
Yeah.
So you are at the end.
We are the end.
At
We are
the
the
line.
end of the line.
End
We are
of the
the
line.
end, and the very end.
Yeah.
That's correct. Yep.
Yeah. You know what,
Exactly.
doctor? I can talk to you forever. It
Oh, it's
seems
nice to
like
talk to you.
it's
Thanks.
really like a lot of information that you have given
That's
really
great.
today, and I know that I'm sure I'm missing a lot of things.
No. I
here,
think
you
it was
know.
a great conversation.
But
Thank you.
I think we are running out of time, so
That's good.
we do have to kind of stop. But
Yeah.
we hope to you come back again with
Sure.
something that you have done great, futuristic, and you definitely want to tell
Sounds
our
good.
viewers that.
Thank you very much. That's
Yeah.
great.
Thank you for joining us
Thank
today.
you.
If you have any questions, comments, you can email me at rajmitv@gmail.com. That's again rajmitv@gmail.com. You can watch our prior shows on YouTube at youtube.com/Infosys International. That's again youtube.com/Infosys International. Again, until next time, have a great week. Thank
Thanks
you.
very much.
Thank you
Thank
very
you.
much.
That was great. Thanks.